Αγαπητοί φίλοι, καλησπέρα.
Καλησπέρα.
Εύχομαι να είστε καλά.
Δρόσεσαι.
Να την παλεύετε από τη ζέστη. Εντάξει, συνήθως όταν έχουμε τόσες πολλές φωτιές και τόσα πολλά πραγματάκια δύσκολα, έτσι, άσχημα, όπως τα νέα της τελευταίας εβδομάδας, συνήθως το αναβάλουμε το webinar, αλλά δυστυχώς, και θα το πω έτσι πολύ άσχημα, δυστυχώς κάθε χρόνο γίνονται πλέον. Και
ο μιλητής είναι από το εξωτερικό.
Ο μιλητής είναι από το εξωτερικό, δεν θέλαμε να τον χάσουμε, δεν θέλαμε να το αναβάλουμε, οπότε είναι και το τελευταίο webinar, είπαμε να το κάνουμε. Η καλύτερη νότα της εβδομάδας, να δώσουμε ένα μεγάλο συγχαρητήρια στην εθνική ομάδα Πόλο, δεν ξέρω αν σας ενδιαφέρει, έτσι, αλλά είναι η πρώτη φορά που πέρασε στον τελικό του Παγκοσμίου Πρωταθλήματος. Είναι μια εξαιρετική νίκη για το ελληνικό Πόλο. Ξέρω ότι δεν σας ενδιαφέρει, αλλά εγώ οφείλω να το πω.
Είδα το 7-5. Είδα το 7-5.
Έλα. Εγώ το είχα στο ιατρείο, αλλά το βλέπα, back and forth.
Αλλά κάπου το είδα.
Έτσι, σωστό. Ισχύει. Δεν θα κρατήσω άλλο το μικρόφωνο. Έχουμε μαζί μας την τεράστια τιμή και χαρά να έχουμε ένα φίλο από το Λίβανο, τον Ντάνιελ Σαντ. Ο Ντάνιελ έχει σπουδάσει στο Λίβανο και μετά έχει εξειδικευτεί στην Γερμανία στα εμφυτεύματα και θα μας μιλήσει για guided implantology. Dear Daniel, thank you very much for being here with us. I will not say, with no further ado, I give you the microphone and the stage is yours.
Okay, thank you. Kyries και κύριοι. This is the only words I know in Greek. Good evening, everyone. Thank you for inviting me. This webinar is actually in collaboration with CardioDental, which is a dental company in the Greek market. So represented by Dr. Karampinis. I bet you know him. I was invited by CardioDental for free. So I'm not given any honorarium or money for that, and therefore I don't have any commercial interest in advertising or promoting any of the products. Given that I'm using root implants, and therefore I'll be showing you cases exclusively with root implants without trying to be pushy or to be trying to advertise it. But I will try to be more or less unbiased in my opinion, and I will show you maybe some features in this dental implant that we cannot find in any other company. So I have like a small company which is called Let's Talk Guided. You can follow it on Instagram and Facebook, YouTube. I do mainly digital planning, very sophisticated ones, very advanced ones sometimes, and sometimes very simple. To do like all on 4 or all on X, usually with immediate or instant loading at the same time. So this is my passion. This is what I usually, in my occupancy in my dental clinic. Okay, so I will try actually to show 2 cases. I don't know if I will have enough time to present the 2 cases. So let's start the first case and see how it goes. Before we jump into the clinical case, I would like to emphasize the importance of evidence-based medicine. I think everyone is familiar with this term, evidence-based medicine, and it means, what is evidence-based medicine means? It means that as clinicians, we deliver, it means that delivery of or answering the patient demands by delivering him the best research evidence or the best treatment scientifically proven. Okay, so this is actually the evidence-based medicine, and we have to try to stick to it every time we treat the patient, and every time we try to answer the patient demands. We have to go dig the literature and to see what is the best option for him, the mostly evident and the best scientifically proven, specifically for this patient. So we have to keep this in mind every time we treat a patient. or every time we have to build a treatment plan for a specific patient. Now, since we're gonna talk mainly about maxillary edentism or maybe also maxillary atrophy, let's imagine obviously for the fastest possible way to have fixed teeth. And in our scientific language or dental language, it means that he will be asking for an immediate loading on immediate implants. Okay. The second, so it means that we need to think about how to reduce the treatment time and the patient chair time, because this is very crucial for him. A patient doesn't like to come visit the dentist. So the less visit he will have, the more appealing it will be for him as a treatment. And then he gonna ask, of course, for the affordability. The more the treatment is affordable, the more it is acceptable for the patient. And since it has to be affordable from the patient point of view, from our dental point of view or business point of view, it has to be cost effective. Again, we have to think about cutting or reducing the time. And also we have to think about cutting the cost. How to cut the cost? Maybe we can consider minimizing or reducing the number of implants, but also very importantly is to think in a graftless way, trying to avoid any unuseful bone augmentation, because bone augmentation usually are expensive, are morbid, and also they are more lengthy in terms of time for the maturity of the graft and for the healing process. So as much as possible, if we want to succeed in our business plan, we need to try to escape any bone augmentations whenever possible. The last demand, of course, for the patient, it will be to have a painless procedure. And in our terms, it means we have to be micro-invasive. So again, we have to think graftlessly, because as I said, and as all we know, that grafting and augmentation are usually painful procedures. And also, if we go back again to be micro-invasive, we're gonna think not only graftlessly, but also flaplessly if possible. So I think this is the formula of success to present dental treatment for any patient, for an dentalist patient. So if we promise him the fastest possible fixed teeth in an affordable and painless way, I think every patient will accept. And I believe that this is the, as I said, the formula of success and to sustain an implant business nowadays. And this is what I'm trying to implement and to apply in my daily practice. And here I will show you how. So again, if we go back to the evidence-based medicine, we have this parameter, which is the best research evidence. So we know the patient values or the patient demands. We know that clinical expertise is related to the clinician itself or to the practitioner, but the research evidence is available only in science and in scientific articles. And this is the most maybe underseen parameter, because nobody wants and nobody actually likes to read a lot and to do the research. So for those who are not familiar with this pyramid, this is a pyramid that qualify actually the level of evidence of any scientific article. Okay, we have several types of articles, scientific articles, and they are actually categorized throughout this pyramid according to their quality of evidence or to the level of evidence. So the more the scientific article is categorized towards the top of the pyramid, like we see here, meta-analysis, systematic review, it means that the statement that it gives us are actually very strong. And on the other hand, the types of article that are categorized toward the bottom of this pyramid, like let's say case reports and expert opinions and even case series or case studies, they are because they are classified or categorized towards the on the bottom of the pyramid. It means that the statement they provide, they are actually very debatable, uncertain, and we have so it's like a base. They are forming the base to try to draw out another more serious studies. So just to keep in mind, for those who don't know, meta-analysis, systematic review are on the top, and they have a statement which is very strong and very hard to debate. And however, on the bottom line, we have very debatable and controversial statements when it comes from studies that are here colored in red. Okay, so just to keep this in mind, because we're going to use it throughout my lecture. Now let's try to answer the patient demands by the most scientific way, according to the best research evidence and to the evidence-based medicine. Okay, so a patient is asking to the fastest possible fix Ts. It means that in our terms or in our language, he is asking for an immediate loading of immediate implants. So what is the essential requirement for immediate loading? And I went to the literature to dig a little bit of scientific statements and data to see what is the essential requirement for immediate loading. Now I would like to draw your attention that I will be showing you statements that I retrieved from different scientific articles, and these statements are actually color coded. Okay, so let's say this statement is in blue, dark blue. It means that this is a systematic review, okay, which is somehow a very strong statement. Okay, and throughout the slides and the presentation, you will be able to relate every statement to which color it's related, and you can this way a little bit appreciate the power or the quality of every statement. Okay, so this is the systematic review, and again, let's see what we are asking. We are asking what is the essential required for immediate loading. Okay, so this is the systematic review. Like more than 12, 13 years ago, it says that it is evident that the core issue to observe during immediate loading is the establishment of the good implant primary stability. So in order to be able to immediately load an implant, we have to seek for a good primary stability. What is good primary stability and how we can measure the good primary stability? Also, another systematic review which says that increased insertion torque helps achieve primary stability by reducing implant micromotion. It means that there is a correlation between primary stability and the increased insertion torque. Okay, so this is the easiest way to quantify or to monitor our primary stability when inserting our implant. It's only by reading the insertion torque. The more insertion torque we have on our reading, the more primary stability we have. This is according to this systematic review in 2017. Now, what is the value of a good insertion torque? How much what is the best insertion torque? What is the ideal insertion torque? Since we know that insertion torque is related to good primary stability. And we can see here again a systematic review that says that there is no strong evidence that insertion torque of 30 Newton centimeter is enough for implant survival in case of immediate loading. Okay, so this means that it seems that 30 Newton centimeter is not enough. So in other words, it says that we have to seek something more than 30 Newton centimeter. So now we know that we have to seek something more than 30 Newton centimeter, but how much more? Let's dig a little bit more in the literature and see what we can drawn out. This is very interesting randomized controlled clinical trial You can see it, it's colored in green. So it means it is randomized control trial, which is like a serious type of article, let's say. And let's see, it says that the specific implant presented, this was the case of Megagen. Okay, so I did this interesting test on Megagen, and they are concluding that specific implant presented a positive linear correlation between primary stability and implant insertion torque up to 50 Newton centimeter. It means that the guys tried to insert implants, and they found out that whenever they placed 30 Newton centimeter implants with a torque of 30 Newton centimeter, and they measured the ISQ, it was, let's say, is a certain value, and then they tried to place implants with insertion torque of 40 Newton centimeter, and they had better ISQ, and then they placed implants with 50 Newton centimeter, and they got even better primary stability reflected in ISQ. But when they reach more than 50 Newton centimeter, the ISQ didn't change. It means that they concluded that we don't really need to go more than 50 Newton centimeter, because there is a linear correlation, but again, specifically to Megagen implant that they found. So they found that there is a linear correlation between insertion torque and primary stability only up to 50 Newton centimeter and no more. And then the second conclusion, they said that higher torque values could cause unnecessary stress to the bone implant system without additional benefits in terms of stability. It means that they concluded that we don't really have to go more than 50 Newton centimeter, because we didn't see any improvement in ISQ. However, we can, on the other hand, we can take the bone to implant interface maybe at risk, and even maybe some implant components at risk. So there is no purpose to search or to seek a torque more than 50 Newton centimeter according to this randomized control clinical trial. Now, this is colored in purple, and this is not a very outdated meta-analysis. It is a 2 years old meta-analysis, and they found again almost the same conclusion. They say that a result cannot be interpreted with clinical meaningful benefit for using either high or regular insertion torque. It was not very clear if there is a difference if we go more than 50 Newton centimeter, or we keep it less than 50 Newton centimeter, because the outcomes are mostly the same. So what we can conclude regarding the insertion torque, we can say that insertion torque is an essential reading to decide whether to load immediately or not. Okay, so this is the most easy way to see and to qualify our implant inside our bone, is to see the insertion torque during our implant insertion. And then we have to know that insertion torque has to be more than 30 Newton centimeter, but not necessarily more than 50 Newton centimeter. It means that we don't have to be crazy about seeking very high insertion torque, or maybe to be disappointed if we didn't reach more than 50 Newton centimeter, because as almost all the literature that say that we don't really have to go further than 50 Newton centimeter, because the results are the same in terms of implant success. Now we were talking here actually about single implant, because almost the majority of the implants of the scientific articles are usually, when it comes to immediate loading and stuff related to insertion torque and the primary stability, they usually talk about single implants. Now, in our case, since our topic is today to talk about full arch, let's see what is going on in full arches. Okay, so what about full arches and the insertion torque? And here a systematic review that says that to some extent use of implants with a rigid splinting may compensate for some optimal stability. So it means that whenever we splint our implants by a fixed rigid prosthesis, we can actually compromise for some of the implant for stability. And this is very significant and it's very important for us. So that means that we can always compromise for some of our implants in terms of insertion torque. So we don't have to worry if out of, let's say, 6 or 7 implants, we have 2 maybe or 3 implants that didn't reach more than 30 Newton centimeter. Okay, literature says that it is well tolerated. Since we have rigid splinting, they will end up in osseointegrating. Also, a very significant case report. This is very interesting. Please pay attention to the statement. This is a case report which was actually reported inside a cohort study. And it says that an implant placed completely out of contact with bone, but splinted to adjacent implant in a fixed prosthesis still osseointegrated. This is okay. This is a case report, but this is a very significant finding. It means that they have appended an implant to a full arch, let's say, prosthesis, and then they have screwed in this full arch prosthesis on the patient jaw when this appended implant was actually floating inside. It was fixed to the prosthesis, but it was floating inside a socket without touching any adjacent bone from any wall of any socket wall. Okay, and it still succeeded to osseointegrate, and this is very significant. No matter what that it is a case report, but this is like a pilot study, let's say, that says a lot, and that gives us a lot about the idea of compromising the insertion torque or the insertion torque or the primary stability from some of our implants during full arch procedures. Okay, please keep this in mind because this is very important and it really works, because I do a lot of full arches and sometimes I lack some primary stability in some of the implants, specifically in the upper jaw, in the back, in the molar area. And whenever I splint them by prosthesis, they still osseointegrate. So I think that now we know everything about how to, or the consideration that we have to take in mind, or the criteria that we have to keep in mind also about how to get fastest possible fixed, and when to immediately load and when to delay the loading. Now we have to think about the affordability, which is the second demand of the patient, and it means that the cost effectiveness. I don't know if you are familiar with these kind of constructions that we see a lot of on social media nowadays. I think this is a way a lot of implants in one jaw. And this is actually increasing the invoice of the patient, because we have to invoice every implant for the patient. So let's try to see if it is really, this is how it works or no. So if we consider ourselves here in the audience, if we consider ourselves like experts, so let's say that this statement will be at the very bottom of the pyramid. And I think that we all agree that the more implant we have in a single jaw, the more challenging is to restore prosthetically from an impression point of view, and also from the passivity fit during the frame of the end and so on. So it becomes very challenging and very difficult to us to ensure that everything is fitting, and also it affects the invoice of the patient whenever we are increasing the number of implants, because usually implant is one of the most expensive things in the treatment plan. So we complicate our lives as dentists, and we also increasing the invoice of the patient, which will affect is the patient acceptance. So this is from our modest and humble expert opinion, and let's see what is the science talking about it. So I found out 2 actually cohort studies that were investigated the same. So the title of the article was, "Does the number of implants have any relation with peri-implant disease?" And they found out that the higher the amount of implants, the bigger the hygiene difficulty, the higher the bone loss, then the higher the risk of peri-implantitis. This is the statement done by a cohort study, which is in almost in the middle of the pyramid. Okay. Another study also investigating the same, and they were saying that implants positioned in the maxilla or those placed with an inter-implant distance less than 3 millimeter are 3 times more likely to develop periimplantitis. Okay, so these two statements are also against placing a lot of implants because they will lead to a more risk of periimplantitis. So more implants equal more problems. And so now we know that we don't have to put as much implants as possible inside mouths or inside one jaw. So what is the ideal number then for implants to restore a maxilla? What do you think? I found out a systematic review that were concluding the following. There is a substantial lack of evidence to determine the optimal number and distribution for implants. This is the first statement. So in like 10 years ago, we didn't know exactly the optimal number and the distribution of the implants. And then the second statement, they were saying that most of the study reported on prosthesis support by 4 to 6 implants. Okay, so almost all the study that were analyzed by systematic review, they were actually reporting 4 to 6 implants inside one jaw. Okay, and then the third statement, whether there is an indication for more than 6 implants is unclear from current evidence. So in 2012, we didn't know if we really need more than 6 implants inside one jaw to have a successful long-term result. Now, what we can say about this systematic review is that it was mixing up maxilla and mandible. Okay, so this was mixing up maxilla and mandible, and since we are talking today more or less about maxilla, this was the topic at the beginning. I found also another systematic review that was focused only including only the studies that were only treating maxilla. And in the maxilla, they found out that 4 to 6 implants would be too limited given the failure rate, which is up to 7.2%. And increasing the number of implants to 7 or to 8 may reduce implant failure to normality. Okay, so just by increasing the implants to 7 or to 8, not to 10 and 12 like we saw on the previous picture. So by only increasing the number to make it 7 or 10, we will normalize the implant failure at the maxilla. Also, a very interesting finding: the longer implants, more than 30 millimeter, better initial implant stability, cross-arch release venting, and balance inclusion are considered important to ensure predictable outcomes. So longer implants is a criteria of success also in maxillary full jaws. Okay, this is also to retain from this study. So now we know about how many implants we have to place. Let's think about the micro-invasiveness, and what do we know about narrow diameter implants? Because sometimes we are led in order to avoid bone augmentations to use narrow diameter implants. And let's see what is the opinion of the scientific literature towards this this matter. So we have actually there is not a lot of studies about that, but there is a guy who was investigating this topic, and he was categorizing narrow diameter implants into 2 categories. Okay, he distinguished the narrow diameters, which were between 3 and 3.5 millimeter in terms of diameter, and he has like a specific category which was like less than 3 millimeter, and he called them mini implants. Okay, so the narrow diameters implants, which are 3 to 3.5 millimeter, we can find on the market. We can find 2 actually type, either one piece like you see it here on the top, and in 2 piece also like you see it here on the bottom. So these are actually narrow diameter. Whenever diameter is less than 3 millimeter, usually they are 1 piece implant like these ones. Okay, So what we can tell, because there is not a lot of evidence in the science about narrow diameter implants, we can see that there is no study, and this is a meta-analysis, the strongest level of evidence that says that there is no study on many implants nor on narrow diameter. So near on these on the right, neither on the left, regarding fixed cross arch rehabilitation. So we don't actually know till nowadays how these implants act in fixed cross arch rehabilitations. The only study that we have these studies on overdentures, like you see it here on the panoramic X-ray, and they say that overdentures over these kind of implants, which are mini implants, have a promising result with a slightly lower success rate. Okay, so they are not as bad as this, but they have slightly a lower success rate, and maybe it is due because it is an overdenture, so the patient is led to remove the denture and put it again several times during the day. Maybe this movement will disrupt the osseointegration, and this may lead to higher failure. So it means that this is what I wanted to tell you, that we don't have enough evidence to see if narrow diameter implants, they behave well in full arches, but it doesn't mean that they don't behave well. It doesn't mean they don't success. It doesn't mean that they fail. It only means that we simply don't have enough material to know if they behave well or not. So what we can conclude is that the insertion torque should be more than 30 and not necessarily more than 50 Newton centimeter. Could be lesser for some of the implants in cross arch splinted configuration that we showed. The more implants is not the better, but the longer is. This is very important. So between choosing if we're going to place more implant or longer implants, our choice has to be longer implants. Okay, so the more implants is not the better, the longer is. Between 6 to 8 implants seems to be the right number for the maxilla. And we have no data about full arch fixed restoration implants which are less than 3.5 millimeter, nor in delayed, neither in immediate load. Okay, so this is a lack of knowledge in this area. Okay. Now, if we go towards our clinical case, and let's see the anatomy of the maxilla. Usually, the anatomy of maxilla is as such. Okay, so here it is colored according, also color coded according to the type of bone. So we have to keep in mind that the more we go distally, the more the quality of the bone deteriorates. The alveolar bone of the maxilla, the more we go distally, posteriorly, the more it deteriorates and it becomes more trabeculous, and we in this area, the more we go back, the more we have difficulty to achieve a decent primary stability, which is somewhere between 30 Newton and 50 Newton centimeter, as we saw. Okay, so just keep this in mind. The more we go back, the more it will become challenging to us to get a good primary stability. Now we have usually this is how the ideal patient will present, will come to our clinic, but unfortunately this is not the case. Usually he comes up with some atrophy. Okay, so the atrophy comes from two things. After your bone extraction, you're gonna have a 3D degeneration of the alveolar ridge, and also you will have from the top the sinus pneumatization. Okay, and this will cause maxillary atrophy, and it is actually it has different stages and different levels of atrophy. So we can see a patient somehow presenting in our clinic like that, when we cannot really insert a decent number and lengths and widths of implants. So we have to seek somewhere in the green areas. Okay, the green areas, or basically which we can call basal bone. It is, to name a few, we have pterygoid plates, we have zygoma, we have the piriform rim around the nose, and we have the vomer. All of these bone structures are first of all, cancellous, cortical, and they do not degenerate with the extraction of teeth extraction. Okay, so only the alveolar bone is subject to atrophies after extraction. These green structures remain almost the same, and they have very cortical bone that we can rely on to achieve the desired primary stability. So we have to think about these areas, and we have to exploit them to the maximum in order not to avoid bone augmentations. So let's see what the literature again is giving us some information about all these different parts of the basal bone. So the pterygoid implant, we can see that we have 95% survival rate whenever we place an implant in the pterygoid plate, which is a high success rate. Also in the zygoma, whenever we place implant, we're gonna have like 98% of survival rate. However, these meta-analysis, which is also a study which is on the top of the pyramid, it says that we're going to have usually, or not usually, very often prosthetic complication, because sometimes we have an emergence of the implant which is very palatal, and it's hard to correct it prosthetically. So this is why they say that we have sometimes prosthetic complications. And these implants have to be diligently planned before placement. Okay, now we have something which is called vomer implant, and this area I used a lot. Only one cohort study, which is there, it reported about 12 implants in this placed in this area, in the vomer area. It means like having the apex of the implant protruding in this. Engaging the vomer, okay, the vomer plate. And they say that the insertion door in these 12 implants, this is the only study that I found that was reporting vomer implants. And it said that whenever they placed the implant inside the vomer area, they always reached a torque, an insertion torque around 50 Newton centimeter, if not more, and which is more than enough to get a primary stability, good primary stability, and to immediately load our implant. So the vomer implant did not appear to lose bone or stability despite their frequent placement in compromised situations. So this is very safe area that we can rely on every time we need to worry about insertion torque. Please try to consider the vomer area. And then also a very important area, which is called lateral periformil, which is the lateral wall of the nose. And it has dense cortex, hardly resolved during the atrophy process, and it allows us to place automatically tilted implant here because of the anatomy of the nose. Every time we have to place a lateral nasal wall implant, we're gonna place it in a tilted manner, in an oblique way because of the anatomy, and it means that we automatically we are increasing the length of our implant, because oblique is longer than a straight line, vertical line. And then also because of this oblique position, it requires more axial pull-out force. Okay, so these implants are usually hard to fail whenever they are crossed, they are splinted in the prosthesis because of their direction. Okay, so because they are not vertical, because they are oblique, it is very hard to pull them out. Okay, so they are very hard to fail usually. So the conclusion of this guy Jensen, who worked a lot on these concepts, he said that the paranasal rim should be exploited before considering zygoma, and this is very important. So whenever we have areas enough to accommodate one implant here, we have to exploit it to the maximum before going and thinking about the zygoma. Also, I would like to shed the light on a concept which is called bicortical anchorage, and in these ways, in these scenarios, whenever we are placing we are engaging the apex of our implants in the green part, we are automatically implementing a bicortical anchorage. Okay, so the first cortex is actually here, which is the let's say coronal cortex, and then we have the apical cortex, which is in green. So whenever we have a bicortical anchorage, the more we have a bicortical anchorage, the more the insertion torque is high. Okay, and it was shown in several studies. It says that apical cortical anchorage can be effective in limiting implant displacement equals higher primary stability. So whenever we are placing our apex inside the green structures, we are automatically increasing the primary stability. So these areas are very interesting whenever dealing with atrophied jaws. Now, I would like to show you how I tackle actually my cases. Okay, so whenever we have a case like that, pneumatized sinus with a lot of atrophies, I'm gonna try to place my first implants here in the paranasal area, okay, laterally to the nose. So if I place my implants here, you can see here on the frontal pictures and on the lateral pictures how I can accommodate these implants, okay? But, okay, these implants, maybe they are like 10 millimeters of length, but if I change the design, they change the micro design of my implant and pick implants like that, okay, please appreciate the anchorage that I have inside the lateral piriform rim. Okay, so I actually only by changing the macro design of my implant, picking another design, I'm actually doubling the length of my implant, which is beneficial to the success rate, as we saw earlier, that longer implants are better for the immediate loadings in a full arch, in maxillary full arches. So just by replacing or picking another implant geometry, we are doubling the length, let's say from 10 to 20, we can say, and we are engaging these apical 10 extra millimeters in a cortical green compartment, which is a cortical bone and which will gives us and secure us a good primary stability, which is definitely more than 30 Newton centimeter. Okay, so whenever I am able to place these two implants like that, usually I can consider that in 90% of my cases, my treatment plan is solved. So after placing these two implants, I will try to place somewhere, two implants somewhere in these areas, which is the anterior maxilla, and why not to engage my apexes inside the vomer implant, because as we saw that vomer implants are very beneficial also in terms of giving extra primary stability. So here we have been able to place like that 4 implants, 2 paranasal implants and 2 vomer implants, and then why not to try to anchor 2 implants in the back in the pterygoid plates, which also shown a very high success rate as we seen in the previous slide. So basically this is how I try to tackle my cases. First of all, I try to accommodate 2 implants, 2 long implants in the piriform rim. Then whenever I succeed to place 2 implants in the piriform rim, I will try to place 2 or 3 implants, or maybe even 4 implants in the anterior maxilla, with some of the implants directed towards the vomer, and then why not to place 2 implants in the back in the pterygoid plate. So now we are ready to see our patient. So this is patient. He has some mild cardiac problems, and this is how he presented, showing when smiling only his lower teeth, because in the maxilla he didn't have any at all, only 4 roots in the anterior. And so this is a simple superimposition that I made to show you the level of his maxillary ridge towards the upper lip when he's smiling. So you can see the ridge is flush with his upper lip when he smiles, and this has become challenging somehow when in order to give him an aesthetic pleasant result. This patient was a very budget patient because he didn't have to pay a lot because he was suffering from a previous implant procedure at the dentist. The other dentist placed like for him maybe 5 or 6 implants. I don't know where. And these implants didn't last more than 6 months. They started to fail one after the other. So he came for a like micro-invasive, let's say, treatment, asking for something which will be very easy for him to tolerate in terms of morbidity and also in terms of finance. Yeah, because he, like 6 months ago, he paid a fortune for his 6 implants, which failed. So this is how his maxilla showing, and the mandible, you can see that he has some distortion here on the left side of his lower jaw. And this is how he presented at my clinic. So he had obviously this implant was mobile, as I remember, it was failing. And here on the left now, you can see that he has a fresh implant failure. I don't know where the other 3 or 4 implants were. Of course, there was an implant here. You can see it again on the sinus, perforated the sinus. You can see it. So this was a tough case, and this was one of my first cases. It's like a 5-old, I think a 5 years old case, like maybe 1 or 2 years before the corona, the COVID pandemic. So I will show you again, just quickly, the X-ray and the atrophies. So I had almost a premaxilla here. Yes, where I can place some implants, and also piriform rims and a little bit of pterygoid plates. Now this is the 3D render. You can see here the bone defect. Yes, the implant failure level here and here and here, and you can see the perforation of the sinus here. I'm pretty sure that there was an implant here inside the sinus that failed. Again, showing it. So you can see here laterally we have some defects and perforation of the sinus. But the sinus was asymptomatic. He wasn't complaining about it, so I decided not to try to convince him to go to see anybody else or to see an ENT doctor because he was not complaining. So I said to myself, I will try to avoid the sinus and treat him with implant without intervening inside the sinus. So again, I choose these 2 kind of implants we have in the root implants. Again, this is not an advertisement because I'm not paid for that, and also I don't have any interest, especially in the Greek market, about promoting these implants. But we know each other, Dr. Karampinis and I, because of this brand. We have some ideas that we exchange every now and then about these implants. So root M, it means that root multi-unit. The M goes for multi-unit, and the root P, it has the same multi-unit connection, but P, it means that it is pterygoid implant. Okay. What's the difference between them? The only difference is the thread design. Here we have a V-shaped thread design, and in the root P implant we have a variable thread design. It means that we have two different designs, thread design in one single implant. So first of all, we have these U-shaped threads or square-shaped threads like that, and then we have the 1/3 apical third is thin with V-shaped threads. Okay, and also, if we go and dig a little bit about the literature says that the systematic review, it says that deep and square shaped threads like these, they increase, like in the root P, I mean on the right, they increase the bone to implant contact. It means they increase primary stability. So I wish that all the implants were actually like these with U-shaped threads. I don't know the philosophy of having only this kind of threads, but I work with them as well. Because in root P we have only long implants because they are dedicated for pterygoid region. Okay, therefore they have to be long, like 16 and up. Okay, so this is basically the two difference. The difference between the root P and the root M, only the length and the U-shaped thread that exist in root P and do not exist in root M. I'll show you the idea of having these two different thread design in inside one implant. So this is called an anatomy adapted implant. This anatomy adapted implant has the U-shaped threads that will condense laterally the cancellous bone of the tuberosity, and this one apical third which has a very thin part, it will engage inside the safely inside the pterygoid plate. And the virtue of this implant that sometimes you don't have to drill throughout the pterygoid plate. You just do a small marking whenever you are drilling. You will feel that you are hitting, if you are drilling the inside the tuberosity, you will be feeling that you are drilling inside butter, yeah. But when you drill, the tip of the drill will hit the cortical plate of the pterygoid plate, you will feel it immediately. Okay, so once you feel this hit, you don't have to drill throughout the pterygoid plate from one side to the other, but you will only have to do a small marking of, like, let's say 0.5 millimeter or 1 millimeter inside the pterygoid plate, and then this implant usually will perforate it by the pterygoid plate by itself. And this is a very safe procedure because we are all afraid of damaging any anatomic structure with our drill whenever placing these implant or preparing the bed for such implant. And this implant actually avoid us to drill beneath the pterygoid plate, because it will hit the pterygoid plate, it will be engaged inside the marking of the that we have done with the drill, and it will perforate its own way inside throughout the pterygoid plate. So this is why this implant is anatomy adapted, because the wide threads are dedicated to condense tuberosity and to get some primary stability, and the thin part is in order to engage safely inside the pterygoid plate without having to drill a lot behind the pterygoid process. Okay, so why do I like these implants? Because first of all, they are solid implants. Yeah. So this means that we don't have any hollow inside, but because there is no connection inside the implant, but the connection is outside on the multi-unit abutment level. So we can say that it has an external connection, let's say. So therefore, it is thin, and the manufacturer can fabricate these implants in thinner diameters without compromising on its mechanical properties, because we don't have a thin walls, because the implant is not hollow inside. Yeah, the implant is solid. So it means that since it's a thin, it is more micro-invasive, it is more versatile, and sometimes we can bypass the mandibular nerve, and sometimes we can avoid, many times we can avoid bone augmentations because it is thin. From the implant abutment level, it is tissue level. Okay, so we have to insert the implant somewhere up to this pink neck. Okay. Up to here, somewhere here. I don't know if you see my drawing. So this is the bone here, and we placing it somewhere like that. So this will be emerging inside the gum. Okay, that's why it is a tissue level implant, not the bone level implant. So that means that we are displacing the interface between the implant abutment towards the coronal part. So all our interfaces are away from the bone, and all the micro movements, if it happens, all the micro movement and the micro gaps, they are away from the bone. Again, it has, as I said, external connection, as you can see, and because it has an external connection, it has an axis compensation up to 60 degrees, and this is very important. In atrophied jaws, like I'm showing, we are not placing the implant in the ideal prosthetic position. We are chasing the remaining bone stock in the maxilla, and therefore we don't have control in our prosthetic axes. So sometimes we are very oblique, and with these implants, we are able to screw retain across arch prosthesis, even if the implant are divergent or convergent up to 60 degrees, which is huge. 60 degrees is huge. We rarely reach these angulations between our implants, even in atrophied bone. Also, very important thing that this is screw retained implant, so we are avoiding any risk of cementitis, and we can easily retrieve the prosthesis at any stage whenever maintenance has to occur. Let's say we have a fractured porcelain or something going on under the prosthesis, we can simply unscrew the prosthesis because it's always screw retained. Also, a very important fact that this this implant has a bulk screw. Look at the diameter of the screw between the prosthesis and the implant itself. It has double diameter in comparison with any other multi-unit implant system. Okay, so therefore we can torque it way more, and it is way fatigue resistant. So it is rarely that these screw loosens with time, because they are more torqued and they are more fatigue resistant because they are big. So this is basically the advantages of having these implant or working with these implants, especially in atrophied bones and in all types of atrophies, because no matter how we angulate or how we direct our implants, we will usually will be able to correct and screw retain the axes because they are tolerant up to 60 degrees. So this was my planning. First of all, I started to simulate two implant placement inside my paranasal walls. And here you can see that I've I tried to place a root pterygoid implant. So these implants are usually dedicated for the pterygoid plate, these root P. But here I found a very nice and very interesting use for them in the pterygoid rim. They almost always fit inside this region, and they are also very anatomy adapted to this region, because usually we have here a lot of bone, and whenever we go apically this way, the bone started to strangle it in this way. So we need also larger threads at this region, and we need something which is very thin in order not to go out inside the nose or in the sinus. So this is also very anatomy adapted. The root P is very anatomy adapted to this area, to the pterygoid, the paranasal area. So usually when I try to place, as I said, two implants in paranasal area, I try to start with root P and to see if they can fit here. So they obviously, and luckily they fitted. And then here, because the tuberosity was very small, as you can see here, I was not able to fit a root pterygoid implant, but I placed a root M implant because it's thinner. Okay, so I practically switched the indications of these two implants. So root M in the back, however, it has to be root P usually. This was the purpose of root P by the manufacturer, and root P here. And then the last two will be somewhere in the anterior maxilla. So once one implant engaged in the vomer to ensure a good primary stability, and I placed one implant somewhere outside the fresh socket in order to have better bone to implant contact all along throughout the whole length of the implant. So this was my distribution of the implants, and I will show you here. I don't know if this is yeah. So this is the animation, the simulation of how I place my two implants. Usually these implants have to protrude the pterygoid implants have to protrude in the back. Yeah. And here are my 2 implants in the paranasal area and 2 implants here, one in the middle, engaging the vomer, and one somewhere outside the fresh socket. Here I have taken a screenshot, which is very interesting. You can see so this is the nasal floor. So usually with your implants, regular implants, 2-piece implants, we're gonna reach somewhere here, okay? But because we have these implants with a thin apex, look how far I went. So this is, you see the nasal floor, and look how far I went with this implant design because of this virtue or this design, which is a thin apex. So imagine how much engagement in the cortical bone I obtained only by using this kind of implants. This is very interesting. Okay, and because as I told, it was a very budget treatment, so I promised him to be a very patient-friendly treatment, and I promised him to deliver him the cheapest prosthetic solution, which was, of course, a acrylic hybrid prosthesis. So because we agreed on that, and because the hybrid prosthesis has to have a component like maybe 10 millimeters of pink acrylic, it is mandatory in order to hide this metallic bar inside. We need to coat it with a pink acrylic. So a hybrid acrylic prosthesis is not possible to make it without a pink component. Okay, it's not like a ceramic. Every time we need to do a prosthesis, an acrylic prosthesis, acrylic hybrid prosthesis, it is an FP3 prosthesis, and it has to have at least 10 millimeter, I think, of acrylic pink component. So if you place it like that, you're gonna see that we're gonna have an artificial gummy, very unpleasant smile, because I showed you that the patient ridge was somewhere here, flush to the upper lip. So if we place it the prosthesis on the top of the ridge, we're gonna end up with a result like that. So whenever the patient will be smiling, he will show only the artificial pink material, and his lower teeth will be hidden somewhere behind the lower lip. So what was the solution? The solution was to cut away a portion of his ridge. Yes, somewhere to this level, in order to have this 1 millimeter hidden here. Yeah. So ridge reduction in order to level up the whole prosthesis and to reveal the patient teeth on the maximum smile, and not only the acrylic. So for this purpose, a guide was designed. Again, it was one of my first cases, maybe 5 years old. Of course, the guide has improved, all the prosthetic workflows has improved, but these were like one of my first guides that I have ever made, maybe the second or the third guide. So this guide is actually composed of several components. First of all, we're gonna name this one master guide, and we're gonna place throughout this guide, we're gonna place two pterygoid implants, and then we're gonna place the 2 paranasal implants. Okay, and then we have here the bone reduction guide. This guide will guide us. This shelf actually will guide us to reduce the required amount of ridge in order to hide his artificial gummy smile in the future. So once we place our 2 implants and once we do the reduction of his premaxilla, we're gonna overlap this on the top of this one. Yeah. So this is an overlapping part, and when we overlap it, we're gonna place our 2 remaining implants, one in the vomer and one laterally in the premaxilla in the lateral region. So this was done concerning the surgery, and then because we are talking about immediate loadings, I also designed something which will be overlap also on the top of this. So once we've done with the surgery, we're gonna remove this one and we're gonna place this one. And here we're gonna have some 2 waxes like here in order to take the occlusion, okay, to register his vertical dimension and the occlusion. And here we have embedded the 3D printed teeth inside this occlusal rim that will help us to assess the length of his smile. Yes, if we have to lengthen the teeth or we have to shorten, and then we're gonna speak of this one later on. So this was the day of the surgery, and as I showed you before that we had some distortion here at the lower jaw. So before starting the surgery, at the same day, I did something provisional, like a let's say like a snap-on smile that I 3D printed and glued on these ceramics for as a temporaries in order to have a good occlusal plane and a good prosthesis on the top. So these were the snap-on smile that I designed and glued on this on the day of surgery, and we started with the surgery. So this is the upper jaw. We engaged the first guide. Okay, we place our 4 implants, 2 in the pterygoid area and 2 in the paranasal area, and then we do our ridge reduction, flush to this ridge reduction guide. And then we remove and then we place our second small guide, this one, on the top of the master guide, and we place our remaining 2 implants. Okay, so now we have the 6 implants on the placed inside the patient mouth, and now at the same part we're gonna enchain with the prosthetic part because we promised the patient to deliver the prosthesis as soon as possible. Okay, so again, would we go to digital impression or with an analog impression? Okay, we nowadays we all speak and talk about digital impressions and the digital dentistry, great, but unfortunately, if we go to the literature again, and remember this case was like 5 years ago was done, or maybe 4 years ago, we are actually able to do it. This is done on the model, but I can show you that it can be done. Yes, so this is how we take an intraoral impression. It's a bit tricky in the patient mouth because there is blood and moving mucosa. On the plaster model, it's way easier, but it is possible. Okay, so but let's see what the literature is talking about digital impression on implants for full arches. In the case of long span restoration, and this is a randomized controlled trial, which is, you see green here. It's done, it's not a very old randomized trial, and it says that in the case of long span restoration, in particular for full arches, intraoral scans do not yet seem to be sufficiently accurate as reported by several studies and reviews of the literature. So, and they say the statement, the literature has not yet validated the use of intraoral scanners for full arch implant impressions. Okay, so please be aware of that, like two or 3 years ago, and even I think now, it is not still validated totally to use intraoral scanner for full arches. However, it works. There are some ticks and hints that helps us to get an impression, but it's very tricky again. It's very challenging. It's not very predictable. Also, another study done like more recently, and it said that the article title was full arch implant impression taken using intraoral scan are not sufficiently accurate for application, and they say that accuracy varies greatly with inter-implant distance. So the more the distance between the implant we have, the more it's tricky and challenging to take a an accurate impression. And the scan body type also plays a role. Intraoral scanner type also, and operator experience. And imagine we have a distance between the pterygoid implant and the paranasal implant. We have maybe like 2 or 3 centimeters between these two implants. Imagine how it will be tricky to take this impression. So for these actually reasons, I very rarely use intraoral scanner for full arches. Yeah. So in this case, we've made an analog impression, but with a twist. It was not an ordinary impression. Look what I've done. So after I have placed my implants and I removed the small components, which was this one, after placing it. So I overlap this part on the top of this, and I got something like that. Okay. And I asked the patient during the same session, I asked the patient to bite. So I registered his bite. Okay, and here I placed this small part, which is, let's call it buccal shield. So I placed the buccal shield here in order to prevent the lip to fall inside this this hole, yes, and to give a natural look of his lip while assessing his smile. Okay, so I've clipped, I have designed here, so you can see these small markings. So these small markings were actually to clip off this shelf in order to free the lip, in order to avoid any interposition of the lip while smiling. But at the same time, I've placed this buccal shield in order also prevent the lip to fall inside. And I think this has give us like a natural look of his lip. So I've registered the bite and I assessed if we have to shorten or to lengthen the tips or the incisal edges. And you can see here that yes, it was a little bit, this is what the patient was on relaxing position. So I had to cut away maybe a couple of 3 millimeters of his teeth like that. Yes, so everything, so this information was transferred to the lab. And so I removed this part, and then I took the impression with my master guide. So through the holes, this is the most individualized impression tray, yes, because it fits exactly on patient mouth. So through the holes, or the guiding holes, I placed my impression coping like that, and I consolidated them with some flowable composite. Okay, so I glued them actually with the master guide, and then on the top of that, I've placed the 2 impression copics in the front, and reused this small compartment after filling it with the plaster. So I filled this small part with plaster in order to register the new position of his new gum, because it was resected. And I've overlapped this small part on the top of the master guide. So once the plaster is set, what is happening? So once the plaster is set, you can see how this is how the impression looks like after I have retrieved it from the mouth. So the 2 implants in the back, 2 implants in the paranasal area, and these 2 implants here, and the plaster giving me the new position of his gum level. So now we are converted this way, our guide into impression tray, and now this is all that we have to provide our dental technician. So we give it to the dental technician. The dental technician pour plaster here in the intaglio in the impression tray. Once it is set, the master model is set, we're gonna remove the small part. This part we're gonna remove it, and we're gonna remove all the impression coping from here. Okay, and then we're gonna overlap the bite rim. Okay, so we're gonna overlap this again on top of this, like that, and then we're gonna take everything to put everything in occlusion like that. Okay, so this is done in a single step. We have all the data and the material that we have. You can see that he has the bite, and you can see that we have told to the lab technician that you have to cut away 3 millimeters from here. Okay, and they have the implant position and the gum level and the occlusion and the vertical dimension and the anterior level of his incisors. So the lab has everything, and he will take the castable abutments and do his job and deliver the next day or next, let's say the day after, the prosthesis like it was agreed on. Yes, so he has provided a hybrid acrylic prosthesis, and the nice thing in the acrylic prosthesis that you can add, remove as much as you want from the intaglio of the prosthesis. This is very important because it didn't came like that. I can ensure you that lab dental guys, sorry for that, they don't understand how to make cleansable and avoid intaglios and undersides. They always give us prosthesis like with flanges, and it doesn't work for implant work because it will create peri-implantitis. Whenever you have uncleansable undersides, it will accumulate plaque and it will induce peri-implantitis. So therefore, because it is acrylic, I will take my time before the delivery to polish out here all the undersides to make them round, okay, especially next to the implants. Here, okay, it's tolerable because it's like pontics between two natural teeth. It is tolerable to have these flanges, but whenever we are approaching the implant, you can see that all the concavities, they will be converted into convexities. Yes, so they will no food accumulation out of the implants. And this is very hard to explain to any dental lab technician, unfortunately. So this was the day of delivery, like maybe 2 days later, without any try-in, because we have done here a rigid actually impression, because it was plastic and we had here in the front plaster. So I didn't bother myself to do a passivity fit check. Everything was delivered at once. Okay, now we are approaching the end, and I will show you the video. I don't know if the music is loud. Let's assume it's not loud because I don't know. Here. And this is like maybe 5 minutes video, and we will end up, I think, the presentation, but you will see the whole procedure in video. You can see all these videos in my YouTube channel and Instagram and Facebook, which is called Let's Talk Guided. Okay, Let's Talk Guided. So this is before we start to our surgery on the upper jaw. Did it as temporaries because it was planned later on to rework his lower jaw, okay, in a prosthetic way. You can see the first implant, which is placed in the pterygoid area, and you can appreciate the insertion torque. This is the second pterygoid implant. Okay, see the insertion torque, which is very high. Again, we do not need that much torque, as we saw in all the literatures that we have skimmed. We need something around 50 Newton centimeter. And you can see here, I will show you also. So you can see here, I've done these small markings on both sides of the guide. Here you see where I cut through. So these markings serve not only to clip off this bone reduction shell, but also to guide my incision, my vertical incision. You can see here, so this the incision was discontinued because of the plastic. So this is the marking on the coronal side, and there is a marking on the apical side, like here. So prolonging my incision like that. So I remove my here. So I did my incision and I removed the guide in order to make a apically repositioned flap in order not to lose any keratinized tissue, yes, after bone reduction. And this is my two remaining implants in the paranasal area. You can see the design of this implant, which is very anatomy adapted in this area. And you can see again the height that you can reach in these areas with these specific implants. Yeah. So the tip of the implant will go and engage very high in the paranasal rim. So here we are doing the ridge reduction in order to hide our future pink acrylic and to avoid any gummy smile. And after that, we are placing the small guide on the top of that in order to drill and place our two fully guided implants. Here, apical flap repositioning. So I didn't cut any of the gum. I only repositioned it apically in order to preserve all the keratinized tissue. And then this is the prosthetic part in the same session. Here the buccal shield in order to give the lip the normal posture. And the registration of his bite, and also the conversion of the master guide into the impression tray. And here you can see also the plaster that I'm placing, retrieving now the impression tray with all the impression hoppings. And this is what I've showed you earlier on the previous slides, how it is done in the lab. Okay, so this was the case, and you can see this was the pre-op, this is the post-op, and you can see here we have done some work on the lower jaw, and it was like a 3-year follow-up, and everything seems to be very, very stable, yes, 3 years later. And now we are at the 4th year, or maybe even at the 5th year. It was like maybe 2 years ago that I've reworked his lower jaw, and we've done a panoramic X-ray of control. And here, this is the lateral ceph. Again, I would like to draw your attention on one interesting point. Here, look at the nasal floor and look how high we are here. Yes, towards the nasal floor. And this is only achievable with this kind of implants. And I bet that the company wasn't aware of that at the time of the design. Okay, this was like a maybe discovery that I've done by trying to fit in every time these kind of implants in this specific area. Here you can see that we have gone some couple of millimeters also in the vomer, and until now everything holds. I don't know if we have time to proceed with the second case, which is shorter. Guys, I don't know, please give me your insight. Should we go to the second case or should I conclude? So I cannot see, I cannot hear anything. Are we still?
Daniel, I think you can go. It is very interesting. So we want to hear it.
Okay, so it will be like maybe more than not more than 15 minutes, let's say. Okay.
Okay, thank you.
Okay, so this was the second case. Also, this lady, she went throughout a lot of dentists in my town, and every dentist was actually giving her very expensive treatment plans, and very also, let's say, lengthy treatment plans that involves a lot of bone augmentations. You're gonna see why. Okay, and someone referred it to me after she visited a lot of big guys in the city, and she ended up at my clinic, and I don't know how she trusted me. Also, it is an old case. Maybe it was also before the COVID era. Yes, maybe directly before it. Maybe it was like in 2019, let's say. So this is her arch. You can see the V shape, and you can appreciate the atrophies on both sides. And she had like me only 3 teeth left, with all these provisionals relying only on these 3 teeth. Yes, 1, 2, 3. Okay, so I've tried to again to place. You can see here the 3D render again. You can see the bone defect laterally, and here a 3D defect laterally and vertically, and here also the big atrophies. So my treatment plan was again, I tried to start with the digital smile design to do a, let's say, facially driven, first of all, facially driven implantology, and then at the second stage, a prosthetically driven implantology. So first of all, I do, let's say, a face scanner or a 2D photo, and I try to make a nice smile design. And then, according to my smile design, I try to accommodate as much as possible my implants to fit inside the prosthesis. Okay, and this is the cool thing about the digital dentistry, that every step can be pre-planned proactively before the end result, and we can appreciate and evaluate the final result before even doing the surgery. And this is, I think, amazing. And you'll see that she will look like this in real life, especially in her prosthetic, in temporary prosthesis. Again, trying to play with my favorite implants. These implants are favorite only for full arches. Okay, for single tooth restorations, I never use them because they are non-hexed, they are non-engaging. Okay, so you will have the crown rotating around the implant in 360. Even in maybe short span bridges, if we have 2 or 3 implants, I don't really use them because I'm afraid of screw loosening. However, it still didn't happen, but I don't know why in my mind that if I would have like 2 or 3 implants with this short bridge, I don't know why in my mind I'm expecting some screw loosening with time, because it's like you know, an external connection, and the connection is only relying on the screw itself, like an internal or external hex, and we all know that internal hexes, they tend to screw loosen. And here it is even, I think, worse because it's an external connection. Okay, so I have some cases with short bridges that I was obliged to use these implants because of lack of bone width, and the patient didn't want maybe to augment his bone, so I was obliged to place this implant. And so far, these implants are okay. I'm not seeing a lot of screw loosening, but this is my only feeling. It's not based on any clinical data collection or something. This is on my proper feeling. However, for full arches, I'm very comfortable with these implants because since I'm placing 6 to 7 implants per arch, I'm expecting to have less screw loosening, especially that these implants have, as I showed, a very big screw. Okay, so it is very easy to torque it, and they are more fatigue resistant than other systems with multi-unit abutments. So here in this here, sorry. This was my implant distribution. I've succeeded to place 2 implants here in the anterior area, and please keep in mind that this is in the maxilla. This is the best area to give a good primary stability. Okay, the more we go back, the more it becomes more challenging to achieve a good primary stability. So we have to exploit or to get advantage at the maximum from this area, because it's usually gives us a good primary stability. Okay, and then when we go more and more towards the back, the primary stability will be deteriorating. Let's show you again. No, this is okay. So again, the distribution of my 6, 7, 8 implants. Okay, as I told you, in the maxilla, especially with these thin implants, I think minimum is 6. Okay, and maybe between 6 and 8 is the ideal, as shown by all the studies that I presented. So again, 2 implants in the front, which was very crucial for our implant immediate loading, and then 2 oblique implants somewhere touching maybe the sinus, or maybe yeah, you can see the sinus. So I was able to accommodate it, fit these 2 implants directly in front of our 2 sinuses, and then 2 short implants in the molar area. And I can assure you now that these 2 implants will not give me any primary stability. So in terms of immediate loading, at the time of implant placement, if I had removed these 2 implants, or if I have avoided to place these 2 implants, I think that the result would be the same as in terms of primary stability, because these implants are usually thin, and the tuberosity is very cancellous at this level, and it is very hard to achieve any primary stability. Maybe for a delayed, in terms of if we think about the delayed loading and the longevity and the long-term result, yes, it will give us some strengths for the whole construction, but we cannot rely on these 2 implants in these areas if we are trying to achieve a primary stability. I don't know if I've made myself clear. I mean that if we are trying to place these 2 implants here, yeah, in the front. I don't know if you are seeing my mouse. Let's see it again. So I mean that if we are placing 2 implants here, and we are not reaching any primary stability, and then we are placing our 2 implants here, and we are not reaching any primary stability, and we are thinking that let's try to place these 2 implants, maybe we're gonna give some primary stability. Be sure that it will not happen, because these are the areas that we cannot rely on to get primary stability. So the primary stability has to be achieved first from here in the anterior maxilla and the pterygoid region, and also the nasal piriform rim. Okay, these implants at the early stage will not give us any advantage. Maybe on the long run, yes, they will hold on as a whole structure, yes, but not for an immediate loading. Okay, so let's see how I've placed my implants. We've discussed already the bicortical anchorage, and we're gonna go back again for the on the next slide. So in the maxilla, I'm always trying to get primary bicortical anchorage whenever possible. Bicortical anchorage, it means that anchoring my implant in the coronal cortex and also in the apical cortex, okay, like that. And here, look what's happened. I am actually inside the sinus. Yes, I'm not elevating the sinus, but I'm perforating the sinus, because I haven't done any sinus floor elevation here, nor internal nor external. Okay, so here I have perforated the sinus, and we're gonna see if it is okay or not. Here we have placed a more than bicortical anchorage. It's like 3 cortical anchorage, because first of all, this cortex, and then the apical cortex of the tuberosity, and then we have the cortex of the pterygoid plate. Okay, so this is a tricortical anchorage, and the engagement of this apex and the cortical anchorage will give us more than 50 Newton centimeter. This is for sure. On the same side, on the other side, the same. And here again, look, trying to get bicortical anchorage. You see, every time I place these implants, I try to not only to touch, but I have to perforate with the apical cortex. Here, I didn't do it, I think for a reason, because the company didn't have longer implants. Okay, so this was, I think, what was available in stock. And again, since these 2 implants are in the frontal region, in the premaxilla here, usually we don't have to go very deep, because the bone is type 2 bone, and usually we're gonna have a good primary stability without any problem. Okay, so we have a sinus penetration and apical cortical anchorage. So again, what about bicortical anchorage? I will show you just 2 studies. So here, guys have done a like a clinical trial. Okay, so here they have cut away the cortical bone, the coronal cortex. Okay, here we have no cortex, so there is no cortical part here. Here, so this was done only a monocortical anchorage, but in the apex. So apical monocortical anchorage. Okay, and here we have a group that have done a bicortical anchorage. So we have an engagement in the cortex, or coronal cortex, and the apical cortex. Okay, and then here we have a crestal monocortical anchorage. It means that we are not reaching the apical cortex. We are only reaching, placing our implants in the coronal cortex. And what is the conclusion? It can be concluded that insertion torque values and the implant stability coefficient are influenced by cortical bone contact. Since bicortical bone anchorage led to a higher insertion torque and a higher primary stability coefficient compared to the other tested bone anchorage. So they say that bicortical anchorage, which is this one, is better in terms of primary stability and in terms of insertion torque. And this is a proof that, well, this was done in, I think, on the mandible. These X-rays actually are on the mandible, and I think that they are more significant even on the maxilla. Okay, but let's generalize it to the maxilla and the maxilla and the mandible, and we can conclude that whenever we are placing an implant with the bicortical anchorage, we're gonna achieve a better primary stability, and this is very logical. I think we don't have a lot to discuss or to debate it. Another study, again concerning the bicortical anchorage. So you can see here we have done a subcrestal implant placement. So the implant is touching here the only the apical cortex. Here no anchorage. In the coronal cortex here no anchorage at all. Yes, and here we have only anchorage at the coronal apex, and here we have a bicortical anchorage. So this is the only bicortical anchorage. Okay, and here no cortical anchorage at all. And this is the conclusion. Subcrestal implant placement decreases the stress in the crestal cortical bone around dental implants. So subcrestal, whenever we place the implants like that or like that, we are actually decreasing the stress in the crestal cortical bone around the dental implants. Okay, and stress usually leads to bone resorption. So whenever we are placing, we are avoiding the cortical, the coronal cortex, and we are deepening our implants, we are avoiding the bone resorption, regardless of apical anchorage. However, apical cortical anchorage can be effective in limiting implant displacement. It means that they say that whenever we are placing our implant in apical cortex, it's better. It gives us better primary stability. So if we have to use between this and this, according to this according to these authors, they will prefer to have this. So according to their conclusion, they will say that it's better to have a monocortical anchorage from the apical side, because avoiding the anchorage in the coronal side in order to avoid any bone resorption. This is according to them, but with my implant design that I'm using, since my implant is a two-piece implant with a multi-unit abutment, it's impossible to avoid the cortical anchorage. Okay, so it's not applicable. It's not applicable in with my implants, because my implants are have a multi-unit abutment which is embedded, and it has to protrude from outside the implant, from outside the bone. So in my while I'm using my implants, I tend to always do a bicortical anchorage, not by choice, but because of the implant design. So what about the sinus penetration? You have seen that we are penetrating the sinuses sometimes, and look what we can see again from out of the literature. This is a study done, I don't know, yeah, in dogs. Okay, so this is a study on animals, and they say that despite the protrusion extent, penetration of dental implant into the maxillary sinus with membrane perforation does not compromise the sinus end and the implant osseointegration canine. Okay, so there is nothing wrong is in protruding our implants inside the sinus, even if we perforate the membrane. Okay. Okay, also another study that said within the limits of the study, dental implant emerges into healthy maxillary sinus. It's considered a safe and successful procedure. Okay, so the emergence into healthy maxillary sinus is considered safe, and there is no problem at all. Also, another clinical literature review. So this is a very high level of evidence. The third one, they say that we can conclude that the success rate of penetrated implants in the maxillary sinus is high. Okay, so the success rate is high without any kind of complications, especially in the case where the sinus intrusion is less than 2 millimeters, and the implant is completely covered by Schneider membrane. So here they say that, okay, if it is, especially if it is covered by Schneider membrane, there is no problem. Here also they reported 7% of complication. The only complication that I have witnessed, it was nose bleeding for like a couple of hours, and that's it. This was the only complication that we have. I never witnessed this because I think my implants are very thin and their apex is very thin. So now the question is, some of the colleagues were asking me, why don't I do a internal sinus lift here and place my implant inside without perforating the membrane? Okay, the reason is that these implants are actually thin, and the smallest osteotome are usually larger than the apex of this implant. Okay, so it's not possible to make an internal sinus lift with a larger osteotome than the implant itself, because I will lose all the primary stability. So I think that this is the only option to engage my implant inside the apical cortex, is to perforate, to drill throughout the sinus, and maybe to perforate the membrane. I actually really don't care if I'm perforating the membrane or not. Of course, most of the cases, I think I am perforating the membrane. It's logical, but as I showed you, all the studies are not against perforating it. Okay, so this was the design. This was the last one. The first case was an immediate loading, which was delivered like 2 days later. Here, the patient had an instant temporaries at the same visit, and then a couple of months later, we have converted the temporary prosthesis into final one. This is the stackable guides, the concept of the stackable guides that we do on a daily basis. And I also design a lot of these design. Wait a minute. Yes, I design a lot also for a lot of dentists, not only in Lebanon, but I have some clients also all around the world. a few, of course, not a lot of them, because there is the concept is very interesting and appealing, but its application is very experience related. You know, it's like a learning curve. You may fail your first 2-3 cases in order to find out how everything works and where are the errors. Okay, again, I will show you how this concept works. So you can see a lot of animations on my Instagram and YouTube page, Let's Talk Guided, for different these are real cases. Okay, these are not animations, these are cases that I design and then animate. And then you can see also in the page also the real clinical photo documentation and sometimes video documentation. Okay, so the patient was coming with these provisions as I showed you, and I have planned the smile design and I've planned also the implant distribution. So we place our first guide. So this is a stackable guide. So we have two components here. This is we're gonna call it master guide, which is in silver, and this is blue. Okay, so we are actually we need to fix the master silver guide exactly in its place how it was planned on the computer. Okay, and in order to have it fixed exactly at the same place, we gonna rely on something which is hard tissue. Here we have the provisions, the patient teeth. Okay, without this blue, if you are trying to fix with our master guide without having this blue component, we will not be sure that it was placed 100% fixed as it was planned on the computer, because we have a mucosa underneath and the mucosa is resilient. So one small push on the left or on the right side, it will let's say engage a little bit the master guide inside the mucosa, and the placement will be somehow inclined or distorted. Okay, so we have to rely on something which is hard, and that's why we do this small component which will be placed over the existing teeth before extraction. And now, because these the teeth are not resilient, they are hard, now we are 100% sure that we are placing our master guide and pinning it exactly as it was placed on the computer and planned. So now we pin our master guide, and only now we can remove this blue component. Okay, that call usually pinning guide, because it allows me to pin the guide, the master guide, and then we extract the remaining teeth, and then we place our drilling guide, and through which we're gonna place our implants like that. And we have a prefabricated prosthesis also at the same time that we're gonna place it like that. Okay, and the prefabricated prosthesis is actually made of it was made of PMMA earlier, and nowadays we are 3D printing it because we have an improvement in 3D printing material. And here you can see the holes, and these holes serves as for the pickup abutments. So these implants, we're gonna place our abutments throughout the holes of these prefabricated prostheses, and we're gonna lute or glue our prosthesis to the abutment that will be protruding from these holes. So 8 holes, 8 implants, it means that we're gonna have 8 holes inside the prefabricated prosthesis, and you're gonna see it. Okay. So this is the real clinical photos. So as you can see, the pinning guide and the master guide. So we are actually using this pinning guide in order to be sure that our master guide is exactly at the same place as it was planned. So once we have pinned our master guide, we're gonna remove and extract the upper floor, let's say. So everything is extracted, and now we are ready to place our drilling guide. So this drilling guide will gives us the ability to drill and to place our implant fully guided. Usually it has to be fully guided. Fully guided means that even the implant during its insertion, it has to be guided throughout the guide. Okay. If we place these kind of in this case of case scenarios, if we place the implant outside the guide without the use of guide, out of my experience, usually the implants are very far away from the axis as they were planned, and we do not match actually the hole of the prosthesis, because the prosthesis is also prefabricated according to the hole of the guide. Okay, so it's mandatory to place the implant throughout the guide, even the last turn of the implant. Sometimes we have practitioners, dentists, the clients who like, okay, remove the guide at the last 2-3 turns where the torque is becoming very high, and they inserted the implant freehand without the guide. And usually this is at the last turns, and whenever the torque is becoming to increase, when it's only then that the implant deviate very significantly from its axis. Okay, so this is very important. If you are doing stackable device with prefabricated prosthesis, you need to place your implant and to insert it throughout the guide, fully guided. These are the implants which were placed, and these were the prefabricated PMA prosthesis, which was also consolidated with this type of guide in order to be sure that also the occlusion is right. And you can see that the abutments are actually you see exiting from the holes. Okay, so this is very accurate. Procedure has to be very accurate. A small deviation, sorry for this word, it will fuck up all the procedure, because it will like maybe take you 1 hour to find out the right exit of maybe one single abutment. Okay, so everything has to be orchestrated, and everything has to be very precise and accurate, because the holes are very small. You cannot do a very big hole of for the prosthesis, because you're gonna fragilize the prosthesis, or you will be led to make a very wide prosthesis, which is very uncomfortable for the patient. So everything has to be very accurate. So this is how, after removing this plastic and unscrewing the prosthesis or unscrew the abutment, which are glued to the prosthesis, you can see that we end up with something like that. Okay, and then we do some polishing and we put back the temporary prosthesis. Now I will skip this because this is very for the specific, very specific for the root users. Okay, I'll skip the slide, and you can see that we are not very far from simulation and the real temporaries. Yes, they're really very similar. This is 1 minute video that shows you the whole procedure. Again, you can see all these videos and even more on my social media channel. Okay, here you can see that the occlusion plane, of course, I didn't left the patient like that. I just put some bulk of composite here, so she has like a balanced occlusion from both sides. Yeah. Okay, so now this is a very interesting part, I think, for you. So this is day 0, day 3, just for the picture. You can see the good healing around the implants. Everything is watertight, and this is 3 months later. She came for the final prosthesis. This, if we're gonna be very scholar, it is called FP2 bridge, okay, not FP1 and not FP3. FP1 with when it is a crown bridge, FP3 when it has a pin component, but FP2 bridge, according to Carl Misch, FP2 bridge, it is when the prosthesis has elongated crowns like these, okay. So this is basically FP2 bridge, elongated crowns without any pink ceramic or pink component. So now she came for the final prosthesis, and also we need to think out of the box to make it easier for the patient also and for the lab technician. So look what I have done here. Again, this is not the standard of care that I do. I have more sophisticated digital workflows, but these workflows are very interesting for those who are not working very digital, okay? So patient presented like that after 3 or 3 months after the maturation period. And now she is asking for the final prosthesis. So what I've done, first of all, I didn't screw out the temporary prosthesis. First of all, I've taken the bite registration. So I asked the patient to bite on the wax. And then I took the impression of her lower jaw and the impression of her upper jaw, okay, without removing the prosthesis. So having this done, now I screw away my temporary prosthesis, and then I place lab analogs. These are not failed implants, but these are my analogs. So I've screwed in my analogs onto the temporary prosthesis. Okay, and then I reinsert all of this inside the impression, this one, the maxillary impression, this one. I remind you that this impression was taken before removing the prosthesis. So this part will fit inside the prosthesis with the lab analogs like that. And then we do our master model. This is done while the patient is waiting for us she's not leaving, okay? Because this is like a 1-hour workflow. So the patient is sitting at her chair waiting for us to finish. So we are placing our lab analog, reinserting the prosthesis inside the impression, pouring our master model. So our master model is poured, and now what we're gonna, this is how it looks like, yes, when the plaster is set, this is how it looks like. And if we remove now the screw of the prosthesis, we're gonna have something like that. Did you get it? Yes, I think yes, it is easy. Okay, so again, impression, lower upper before removing the prosthesis, and bite registration, then removing the prosthesis, screwing in our lab analog, then reinserting my prosthesis with the lab analog inside the impression, silicone impression that I've taken like 5 minutes ago. And then we are putting our master model, and now the plaster has set, and we screw away our temporary prosthesis. Okay, and it will look like that if we remove it. But we don't remove it. We don't remove the prosthesis, but before we remove the prosthesis, we place the upper and lower into articulation, because we have taken the lower jaw and the upper jaw and the bite. So now that we have for the upper and the lower, and we put everything into articulation of the articulator. Okay, so now the has everything, the lab technician has everything, the vertical dimension and the implant and the gum position. And now it's time to give the prosthesis back to the patient. So it's like 1 or 2 hours procedure while the patient is waiting in the chair, let's say. Everything is set, and we remove the prosthesis. We remove the prosthesis, and we screw it inside the patient mouth, and the patient go away. Okay, again, don't forget that this is rigid splinting. Okay, this is like it was splinted with let's say resin pattern, or I don't know, acrylic or composite flow, because it's rigid, the plastic. So we don't have to really to try it in if we are sure that everything was fit and everything was screwed in properly inside the prosthesis. So we do framework. This is the framework done by the lab technician. It was, I think, laser melted, and we don't actually do any try-in because, as I told you, it was taken by a rigid impression since the implants were consolidated by the temporaries. Okay, so directly the lab technician will do the final prosthesis with the ceramic layering, and we can see here that something is canted, and I asked the patient with the lab technician without even to try it inside the patient mask, because it's obvious that you have to realign, to shorten the canine from the side and to elongate it from the other. So everything was done. So first visit was the CBCT plus the jaw scans and the facial scans, which gives us a virtual patient and which allows us to do the virtual planning of the case. Then the second visit, it will be the guided implant placement plus the instant temporization. This is the second visit. Then the third visit was this workflow for the impression. So the third visit after osseointegration is the impressions, and then the fourth visit was the final delivery. Okay, without any try-in, because I was sure about my framework, because it was taken by a rigid splinting, and everything was obvious and seen on the articulator before trying in. So in 4 visits, I gave the patient her smile. This is again the FP2 bridge. We can debate if this case was more onto an FP3 bridge with pink ceramic or not, but in all cases, you can see that the patient at the maximum smile, she shows this amount of teeth, and she is happy with it. I think the result is okay. And this was like 4 years of control, and she is compliant every time she comes in, maybe one in a year for a checkup and a cleaning, and everything is just fine. She just took a panoramic X-ray like 2 or 3 weeks ago because she started to feel some pain on the lower jaw, but I didn't have time to put the panoramic X-ray, the last one in this presentation. This was, I think, immediately after the final prosthesis delivery. You can see the perfect fit and the healthiness of the peri-implant structures here, and I think that it was successful. So some few words, I think, before we close up with the presentation. Again, I invite you to follow my social media accounts. This is Let's Talk Guided. I have also a website, which is letstalkguided.com. So Facebook, Instagram, YouTube, and LinkedIn. Let's Talk Guided. Also, we started to partner with Cardio Dental for these sophisticated planning and guide designs. So everything, whenever someone is interested in plan a case with me, we have to go through Cardio Dental because the 3D printing is done in-house in Cardio Dental. So I do the design in Lebanon in my studio, let's say, or my computers, and the printing is done in Cardio Dental. We have already some clients in Greece, and we have everything calibrated, because we need some calibration between printers, which takes time, between the software and the printing machines. So everything is calibrated, and the easiest way and the best prices are given by Cardio Dental whenever someone is interested. Anyway, again, I invite you to follow my social media accounts, and I'm very responsive. You can ask everything you want on my social media. There is no pain at all to answer. And so I think that's it for tonight. I hope that you enjoyed the lecture and not very sleepy, and that you have learned something, at least something. That's it. Thank you.
We have to thank you. To be honest, what I learned is that I'm very happy that I don't deal with surgery. It's all amazing, but some people think it's very simple, but I think it's a little bit, even though if you get used to it, it seems very simple. You need to pay attention to some details. But if you do that, some cases that would have been challenging, if not impossible, without guided, you can do it. So it was very, very, very interesting. Very interesting. It was wonderful cases.
Thank you. As I told you, you can see a lot of even more interesting cases because, as I told you, this is a learning curve, and everyone has its own learning curve. This was like my first beginning in full arches, like 4 or 5 years ago, in full arches in all the guided surgeries and all the digital workflows. Nowadays, it's more and more complicated, and we have developed a lot of more advanced and complicated workflows. The workflows are complicated, but they make our life easier and the patient life also easier by reducing actually the number of visits and the number and the lengths of the visit, you know. So maybe now we are meeting patients, like let's say 20% of the work is done when the patient in the clinic, but maybe 80% in terms of time is done behind the scenes on the computers. Yeah, so for the patient, like it's for the patients, he doesn't appreciate actually the amount of work which is done behind the scenes. He thinks that, yeah, he's paying for, like, you see, 1 hour for, like, he's paying this amount of money for only 4 visits which are done during 1 hour every time. And this is unfortunate because most of the work is done behind the scenes during the nights.
Well, this is not unfortunate because the patient wants to finish quickly.
Yeah.
So less pain and more quickly.
The better gets.
It's good. I don't think that the patient should be happy for it. Sometimes with extraction, said, okay, doctor, you took it out, my wisdom tooth in 1 minute. Why do I need to pay so much money? He said, it's okay, I can do it in 1 hour and a half if you want, and you pay less. So if it's, you cannot do something fast and quick, you know, quick and efficient and cheap. So more or less you do it fast and efficient, and you charge less.
Exactly.
I'm just joking.
Exactly. I would like to ask how long time, how many hours did you plan these cases? The first one.
Usually now, the first one, I don't do it. It was like, let's say, an experiment. I'm into more and more like a standardized my treatment plan to look like the second one. Okay, so the temporary is already prefabricated at the time of the implant placement. So I have them at the regular pace, you know. So I have, let's say, nowadays I have like 1 or 2 patient per month that are coming because I have like elaborated also a marketing funnel for them. Okay, so they come, like I started to have 1 or 2 patients per month, and I'm tending to have it more. I wish to have like only 4 patients per month, and I will be doing only this 1 week per 1 patient per week, like 3 or 4 days of planning and 3D printing and so on, and the fourth day of surgery and the instant loading. You understand what I mean? So it takes me like the whole procedure with the surgery. I can fit them, if I work on it, like 3 to 4 days, 1 arch. So around 3 days of planning and printing and all the fitting procedures, and then the 4th day I do the surgery. So all in all, it's like,
how many hours per day?
It's
do
a
you
full
spend
day.
to plan?
It's
The
full day.
day.
Full day. Yeah. And then, yeah, it's full day.
Wow.
So because I have work like ordinary general dentistry, I'm always working at night and during weekdays, weekends. But my purpose is to remove all the general dentistry that I don't want anymore to work, to dedicate it to someone else maybe, and to just do 1 case per week, and I will be happy. 1 case per week. So it's like 4 days of work.
Perfect, perfect. Really, and you want to do the surgery exactly the 4th day after the planning. It means you have the case in your mind.
Yeah.
And
Yeah, it's better to have it because nowadays, because I'm overbooked, because I have also clients which are, I mean, dentists for whom I design guides. So sometimes it's become tricky because I have 2 or 3 cases in parallel, and I started, you know, to lose my mind.
I understand that you want to be concentrated on
Yeah.
one case.
Yeah, better to be like case by case, to finish one and to proceed with the other.
Yeah, perfect. Excellent. Really very impressive, I should say.
Thank you.
Bravo,
Thank you.
Daniel.
Thank you.
Bravo, bravo, bravo. Everything was
Amazing.
perfect.
Perfect.
The best way to end the season, because in August, we all go on vacation. I'm sorry,
Yeah.
vacation in Lebanon. Also in Greece, most people are in vacation. If you have a toothache in August, you are in big problem. And if you have a toothache in 15th of August or 14, 15, 16 of August, you feel like you are in the jungle, an aborigine in Australia. Nothing can be done. You cannot find a dentist.
Oh.
It's something of a religious holiday.
So I should do some marketing campaigns in August in Greece.
Yes, yes.
Yes, absolutely.
Yes. But the patients also don't go to the dentist. It's a conspiracy between dentists and patients, and 1 in 1,000 that is in pain, we call it bad luck.
Exactly.
So thank you very, very, very much. I wish you all the best.
Daniel,
Hope we can have the privilege of
having you again.
having you again. Yes. And
Hopefully.
Hopefully. Okay.
Yeah.
So bye-bye. And
Okay.
I finish with Greek. Καλό καλοκαίρι. Θα λέμε το September. We will meet back in September. Okay.
Καλά,
Okay.
σε όλους.
Take care. Bye-bye.
Bye-bye.
Thank you. You were
Bye.
amazing.